you doing,
Not
Bruce?
not if they know me. And you. How's it going, Doc?
Good. Staying out of trouble the best I can, which is very difficult.
Cool
That's
beans.
it. I'm working on one of the things I'm stressing on is one of our naval lieutenants, nuclear physicist, worked on the Nimitz, developed MS.
Ooh.
It's gone.
Really?
He's been on treatment since August. It's gone.
No
So he sent me a video testimonial that I'm putting into a science. It's about 10 minutes long. Science that explains how our therapy reverses multiple sclerosis, which is an inflammatory condition. It's all back to the beginning. It's all inflammation, you know?
Yes, sir. Yeah.
So
getting rid of that puppy.
So I'll send you a copy of that. I can't release it until he gives me clearance on it. Oops.
No, that's exciting. I've got a good friend that's actually dealing with MS right now. I'm going to send him. He's talked to Dr. Amen, but I don't know, how far he's gone down that path. But I told him about your successes, so he's going to be reaching out to you.
Amen doesn't have MS related technology. Okay, this guy. Who knows everything about it now is your buddy Michael Hartford.
Oh yeah, we're working on some legislation together.
Yeah, I introduced the two of them to Tim. He's got a phone call with Tim this week. So I sent him, I called him and we did a quick Zoom, and I showed him the 2.5-minute video that Tim had sent me. So It was impressive. We have now 6 people, 3 SEALs, 2 regular Army, and now Naval.
On the
reversed MS.
MS. Wow. All right.
Yeah. He's 90% better. No relapses for over 6 months. He was 90% better 3 months in the program.
And this is taking the supplements along with some extra stuff based on his labs.
This is all the protocol. This is all the protocol that's based upon, his laboratory results.
Nice. We want to dive into that protocol quite a bit. Yeah. Always got to have a producer to keep me on. It's like a sergeant major punching me in the head, man. So, hey, all right. So, to all our listeners, welcome to another episode of Broken Brains, where we reach out to the subject matter experts in the industry's thought leaders on repeated head injuries and repeated head impacts, repeated blast exposure, and try to present to you, alternative thoughts and processes and treatments on what was happening with all the brains that are being damaged from contact sports, military service. And today's episode is pretty exciting. We have Dr. Mark Gordon with us on there, and I don't know if most of you have probably already heard of him. But if you haven't, Dr. Mark Gordon is the founder and medical director of Millennium Health Centers in Encino, California. In 2015, he released the book Traumatic Brain Injury, a clinical approach to diagnosis and treatment that presents the science and his experience treating all precipitating causes of traumatic brain injury in both active veteran sports and civilian populations. He's also joined with the Warrior Angels Foundation, a 501c3 charitable foundation that was founded by veterans Andrew and Adam Marr to provide services to members of the armed forces of both active and services. And I'll let you know that Dr. Gordon's organization has provided significant financial support to our suffering veterans out there and continues to do so to a large amount of money. And all of us greatly appreciate the efforts done. His services are also featured in the award-winning movie Quiet Explosions, which we just got done discussing, was nominated for 2 Academy Awards, which focuses on healing the stress and kinetic damage that's done to brains of athletes and soldiers in order to help them recover. And for more information, we'll talk about those at the end, TBIHelpNow.org, Millennial Health Centers, and all the other wonderful foundations that Dr. Gordon has supported and founded over the years. Gordon, welcome to the show.
Thank you, Bruce. A pleasure seeing you again.
Dude.
You know what they say, it's best to be seen and then obscene.
That's true. That's true.
So it's good to see you again.
Yeah, it's good to see you again. It was just amazing having you at the conference, sir. I mean, honestly, I had so many people come up to us like, I've never stayed till the last speaker. And you were the last speaker. And so that presentation that you gave on subconcussive trauma, I mean, up until that point, it sounded like it was something that you were aware of. But your protocols focused on, RBI and veterans. So it seems to have given you a new approach for a lot of your protocols. But let's get back. We can start there if you want, man.
Yeah,
I'm all about.
I'll have to acknowledge the fact that if it wasn't for the bad leading to a greater good that you've now generated, I knew that the veterans that I was seeing who were not given the criteria of traumatic brain injury, but were given the criteria of PTSD, post-traumatic stress disorder, that criteria was given to them, or diagnosis was given to them, because they didn't achieve the level of trauma perceived by the VA and DOD to relegate it into traumatic brain injury. It's because they weren't having concussive injury. They were having subconcussive traumas. And the only thing that did was to reallocate my mind from looking at traumatic brain injury, which I now have removed from my literature and everything that I'm writing, and put it as subconcussive concussive, because I think that's more inclusive. Although you have people out there that are trying to refute the use of the term subconcussive as being dangerous. You know what I'm talking about.
Yeah, non-concussive. That ain't gonna happen.
No, but they want to control the narrative. They want to control the narrative. Subconcussive is subconcussive.
Absolutely.
That's it. It's a category of its own. And I believe that over time, that subconcussive sort of like transforms into the equivalence of concussive. Because, with the subconcussive, as you well know, you don't have any immediate symptoms, but it doesn't mean that the mechanisms, the biochemical mechanisms, haven't been started. I mean, the article I talked about, which was mechanotransduction, where you can have shaken baby, you can have minor explosions, you can have riding a sea-doo, or doing roller skating or ice skating, or snow skiing or water skiing, and that repetitive injury. Or the guys with SWIC, the boat operators for the Navy SEALs. These guys are getting that wave pounding, and they're developing all the symptomatology. As someone
I never thought about
blast trauma, trauma.
I mean,
I work with SWIC, and listening to what they do, it makes sense.
Yeah, they drive those boats so hard. They got those harnesses on them. I know, since, this is kind of a problem that once you understand the scale, you can't unsee it, right?
Yes.
And, it was just, I didn't even think about tankers and, artillery people were, kind of there. Then I started thinking about all these other military service related, occupations, like you just said, where you have a lot of jarring of the brain of something that's, I'm a U.S. Guard certified boat captain. I take my boat out all the time, but I don't take it out in a 4-foot seas and beat the hell out of it at 40 miles an hour. So I can't even imagine what that would feel like. But
wait for the next hurricane in Florida.
No. That boat's on a trailer. As soon as that thing gets within 500 miles, this place, man, it's out of here.
It's parked.
I had this big plan to drive it to the Bahamas or something just to get away from here, but all the fuel and costs. I'm like, I'm not there yet. But no, that's I mean, it's just crazy what there's so many ways for you to experience that subconcussive impact, and I think what we're trying to get out there and get aware is much like those Navy SEALs that were in a New York Times article yesterday we talked about. Right. They all experience massive amounts of psychological and behavioral disorders, yet nobody was assuming. They're assuming they're crazy, that, you saw too many bodies, or you've been in combat too long, but nobody was looking at what they do for a job. Right. And I mean, the educational gap that we have to fill right now. And then that just leads to the treatment gap, which, you right now are just, you're into it up to your neck. I mean, you've been doing this for so long. How did you, I mean, is your background a doctor, like a family doctor? How did you get into, just figuring? I know you talked about translational medicine when you're at the conference.
Right. Yeah. My original training was family practice out of Chicago. And I had the curiosity in endocrinology and was sort of like brought under the wing of our head of endocrinology in Dr. Cruz in Chicago. And I didn't realize until I had 10 years after I had graduated from residency in 1985 and 1995 is when I started just naturally going into this area of endocrinology, which was being used for anti-aging medicine. And in about 97, I had developed depression, just out of the sky blue. Developed depression, was put on antidepressants. And my escape has always been reading. So I started reading about this area, and there were a couple of articles that brought me to the thought that, okay, hormonal deficiency changes the chemistry in the brain and leads to personality changes. So I went and had my blood work done, and I was deficient in growth hormone, testosterone, and thyroid. And I had 6 subconcussive traumas in my past. Maybe one of them I was knocked unconscious when a car hit me while I was riding a bicycle when I was 13. That might have had something to do with it. But it made me go to an organization in Las Vegas that specialized in hormone replenishment and got my hormones replaced. And within 90 days, I was just totally different. And I started focusing back in the late 90s on this area. I went back to my patient population and started talking to them about those that were put on hormone replacement based on labs. If they'd had traumas in the past, then almost every single one had a trauma. So they had a trauma that possibly accounted for the hormone deficiency, but when you replenish their hormones, their psychiatric, psychological problems diminished, mitigated, they improved. So that's when I started focusing almost exclusively in 2004 on neuroendocrinology, which is everything about the brain and the chemistry and the hormones of the brain that regulate our personality and functionality. So that's how I ended up into this square.
I just want to focus on something you just said. You went back and looked at your patients. What do you think would happen right now if we went back and looked at the suicides that have taken place? That we look back at everybody that's been diagnosed with PTSD in the military, of which there are at least 400,000 TBI events have happened, right?
Yes.
Massive amounts of PTSD, diagnoses that are going on. What do you? I mean, obviously, we've got to go back. We have this new knowledge now. We have to go back and we have to make rights wrong. Wrongs right, and not blaming anybody or calling for heads on the block. But I think that was your point. You went back and looked at your patient population, identify those that were suffering to get them help. What do you think the military could do now? Or even the civilian population. The amount of, I think, the trauma that exists right now in this world outside from contact sports severely, both, we have 2 large populations, one significantly larger, but, how do we get that started? How do we get these doctors and psychologists to start looking at this differently as something that could be treatable, not just druggable or whatever you want to call it?
Well, I love my psychiatrists that I work with. We've got 23 or 24 that we've trained. You met Dr. DeMaya, who in Florida, who's been with us for 3 years. Her entire outcomes for her psychiatric cases have gone vertical, have gone incredible since she started looking at the hormones, the neurohormones of the body. We trained her 3 years ago. She's doing absolutely great for her patient population. So it means we have to change the paradigm. When you have, a psychiatric presentation, you just don't hand them pills. You do the appropriate laboratory testing. In the presentation I gave you at the summit, I talked about the Max Planck Institute in Germany, which is a major research and development center for neuropsychiatric conditions. They made a very clear point. 1, yes, you have to do the psychometric testing to find out what's wrong. And 2, You have to check their hormones, their neurosteroids, because the relationship is so clear that what allows us to be depression-free, suicide-free, cognitively clear, physically functioning is the chemistry of the brain that regulates the whole body. I use the CPU, the computer, the central processing unit, as our brain. And if the brain doesn't have a perfect CPU, you start losing peripheral factors, whether or not that's psychiatric or cognitive or physical function or ability to play guitar or to learn a new language, whatever it is, are all negatively influenced by the deficiencies. So how to get the right people, and psychiatrists only want to treat people as psychiatric conditions. They don't know that what influences and gives them their depressive appearance or their mood disorders is due to the change in the chemistry. I'll keep on referring to the summit where I presented the papers that have clear when there's inflammation in the brain due to a subconcussive or concussive injury, that it alters the chemistry to allow for antidepressive serotonin to be made, to reduce melatonin so you can't sleep, and to increase a product called kynurenic acid, which is what they believe really causes depression. So we need a total paradigm shift. We need endocrinologists to be the front runners in assessing these people, to see the biochemical. I mean, in March of last year, March is the TBI month, I was invited by the Department of Health and Human Services to give a presentation. And the presentation was between TBI and PTSD. What I did was I sent out a request from our military population. They had 72 hours to sign in to a study. And we had 79 sign in. And what did I do? I looked at their histories. A small percentage, 19 of them, had VA TBI diagnosis, and the rest of them had a PTSD diagnosis. But if you go and ask them, have you ever had any subconcussive or concussive traumas prior to your enlistment in the military? They all said yes. It was MMA and football were the two most common. So here they had predisposing condition, which was traumatic brain injury. And they then, with their active military, their basic training, their entering the theater of war, their exposure to repetitive gunfire and so forth, that pushed them further into the inflammatory level. They exceeded the threshold that their body could handle, and they went symptomatic. So, this is what needs to be looked at.
And there's no doubt, because you don't get assessed for this, is that they were probably in a pretty high state of neuroinflammation from all that exposure before they even joined the military, which just made it worse. I like when you talk, I think Dr. Gordon got to a lot of us there, is that it's logical. The brain, every computer has got a motherboard, can't have, CPUs, motherboard, whatever, right? And you got to keep that, that puppy humming, right? And I think that, the brain having that power of regulation, throughout the body and all that. I mean, just keeping it in that prime state, which appeals to a lot of athletes and military guys, because we're all focused on that, staying fit, right? And doing the right things for our body. So the logic, definitely is there for sure. But, how do we get those endocrinologists in front? How do we try to get and this is where I just, right now we're, between, trying to get a movie started and now another book coming out on the military that I'm writing and this and all that, it's just the scale of this issue right now. The paradigm is so, I don't know what it's, the carnage is so large right now, and we have to get people away from, like, when I talk to my shrink, you lose your son, you go see a psychiatrist. And she sits there and looks at me. She goes, well, Bruce, I've never heard about this, but I'll tell you what, for the last 10 years, I've been sending my teenage football players out to keep playing football because it meant so much to them. And now I know that this is what probably put them here. She goes, I'm appalled And so we have to convince an entire, number one, subconcussive trauma is not even trained in medical institutions.
No.
Athletic trainers, nurses. This is, I mean, getting endocrinologists, and part of this is just part of this huge problem that we have, that the awareness level is at zero right now. Yeah. For this issue and the relation with mental illness.
Yeah. And I think that's the reason why we need to establish a fresh cadre of healthcare providers who aren't jilted by or biased by the traditional training that was devoid of subconcussive understanding, of subconcussive trauma. And that is awareness. This is about getting the awareness, the science out there. And that's what, my presentation was, a whole bunch of science in little vignettes to bring out the fact of how inflammation kills the hormones of the brain, how the inflammation stops the enzyme systems that control neurotransmission, neurotransmitters, the epinephrine, norepinephrine, dopamine, serotonin, all those neurotransmitters that keep us level, and how it influences it. It's like, you're driving your car from Tampa to Destin, at the Panhandle, and you've got 1 gallon of gas. And how far is that going to take you? You're going to run out. And what happens with these traumas is that they run out of the chemistry that keeps them sane, that keeps them healthy brain functioning. And they've run out of the chemistry. And what? We're supposed to expect them to be, cognitively intact, emotionally stable? No. That goes out the window. We lose that.
I mean, we're just talking right now to several organizations who are getting kind of penalized because they deal with what we call OTH, or other than honorable or bad conduct discharges. Right. Well, there's an entire group of people that are mostly homeless, or a lot of them are homeless, right?
Right.
That have these discharges, and the military has nothing to do with them because they're a BCD or an OTH. Well, nobody's looked at what they did. A lot of these guys served in combat, right? Yes. And they acted out. So, all right. So, today's knee-jerk shotgun society, you can only make one mistake. You can't have a second chance at anything. So these poor men and women were tossed out of the military, can't get to the VA, can't get anything. And then organizations that work with them can't get funding because they're bad conduct discharges. Yet we've never taken a look at what you just outlined. Mm-hmm. Is that why were they acting out? And what did they do in the military that could have attributed to their,
you're going to love this story, Bruce. What got me to move from 1995 to 2007 from the NFL, working with NFL and football, and different professional players who were getting symptoms. I did 2 ESPN Outside the Lines that we talked about it. What happened was I got a phone call from an emergency room doc out of Fayetteville. Now, it was, I think, Pine Ridge or Pinecrest near Fayetteville.
Pine Spring, I think.
Pine Springs, yeah. You know it. So her husband, JR, was a Green Beret who had been on 18, 20 missions. And he was being looked at for less than honorable discharge. Why? Because he was insubordinate. Why was he insubordinate? No one knew. So what I did was I sent her a kit. He was the first case that we paid for back in 2007, 2008. I sent him a blood draw kit. They ran it, and the results were sent to me, and there was the answer. We ended up replenishing his hormones. I sent to his wife, the ER doctor, and she ended up treating the husband, and he gets better. He doesn't get discharged. He gets returned back to Bragg, where he's now an instructor. He was taken off the field, out of the theater, and brought home. And he ended up lasting for another 5-6 years.
So he probably retired.
She ended up becoming one of our first docs to be trained. Okay.
No kidding.
True story.
Man, that's
true story. And that's what converted me over from the high-end financial who didn't want to help. And then I went back to the guys and said, look, you guys make lots of money. Why don't you help me with our veterans? Why don't you help us with our active military? they wouldn't have it. So that's what it caused me to leave and why I shut them down in 2009.
Well, I will say that insubordination and being a Green Beret kind of go hand in hand. I mean, that's why we're kind of picked.
You know best. Right?
He might have had a couple of conventional commanders that couldn't handle him, but
Right.
but be able to dial in and find that he was, dysfunctional or
Yes.
he needed help in certain, chemical areas. I mean,
Right.
wow.
So we found his deficiency of testosterone, DHEA, pregnenolone, and I believe growth hormone was also deficient. And one thing unique about those hormones that I just rattled off is they've been found to contribute to what's called treatment-resistant depression, meaning that you put someone on antidepressants, one doesn't work. Put them on two doesn't work. So you change to another set. They're not working. Well, it turns out there have been articles coming out since 2017, if not earlier, talking about specific hormones like the one I like referring to as growth hormone. They found that 61% of the people with treatment-resistant depression had growth hormone deficiency. And within 1 to 2 months of replenishing the growth hormone, their depression mitigated. They reduced or was totally gone, and they ended up with 4 benefits. They slept better. They had brighter minds, they had better interpersonal skills, and they were less emotionally volatile. So reading that, I went into the biochemistry. I work at a molecular level to see how that growth hormone created the improvement. And it's because it helped to drop inflammation was one of the pathways. So it's all back to inflammation, neuroinflammation, and it's all precipitated by stress. Forget about any physical trauma. Just stress causes fractalkine to be reduced and inflammation occurs. And then all the traumas that we've already shared, from blast wave to tankers. I have a medic who would walk behind a Abrams tank and they'd shoot off their rounds. He'd get a shudder. He retires from the military, and 18 months post-separation, he develops a whole bunch of psychiatric conditions. And he's being put on by medication. He's in San Diego, put on medication. They're not working. He sees one of the Joe Rogan programs that we did. He comes into he had 2.5 hormone deficiencies, 2 deficiencies and 1 real low. And when we corrected it, he got better. In fact, I dragged him onto the Dr. Drew show where he talked about his experience. Yeah. So I was invited to Dr. Drew. And anyway, so inflammation, hormone deficiency, these things are extremely important. And then when we look at some of the basic chemistry of our body, like vitamin D, which is a hormone, that vitamin D is directly related to level of inflammation. So if you don't have a good level of vitamin D, you're going to have a lot of brain inflammation that's going to affect the chemistry of the brain and lead to things like depression. If you go and look at the relationship between vitamin D and depression, there's over 1 million articles on vitamin D.
And didn't you say there was like one specific type of vitamin D you have to take? Because most of the other stuff you just, piss out or whatever.
Yeah, it's when you take your vitamin D, DHA, and pregnenolone are called fat soluble, which means that you need to have some fat in your gut to help it to be absorbed. So we give it after a meal. If you take it before a meal, you'll burn through it, the acid in the gut, you won't absorb it as well. So vitamin D3 is, the one that we highly recommend. You can get it with K2, with vitamin K, which keeps the calcification down. What's the relationship? Vitamin D increases calcium absorption from the gut. So what I tell our patients is, because we use high dose of vitamin D because it's unbelievable. It's the miracle hormone if you start reading about all the articles that have come out. So we tell them, when you're taking high dose of vitamin D, don't take any calcium supplements. Don't use Tums, because Tums are elemental calcium, and try not to chew on any drywall. And if you adhere to that, you have no problems with excessive calcium, because the theoretical toxicity of vitamin D is really the calcium that gets absorbed. It's the calcium that causes abdominal pain, nausea, vomiting, irregular heartbeat, coma, and death. Not vitamin D.
So I got to stop chewing on wallboard now.
Yeah, no more
Gosh.
calcium carbonate. Yeah,
God,
no
there goes
more.
my diet. All right. Well, that's we live in Florida. We always assume that if you go out there and sit on the sandbar for a couple of days, you'll be good on your vitamin D. But
a couple hours with the arms and legs exposed, it usually works. But I've got surfers here. The water's cold in California, so they tend to wear a wetsuit in the chest and hands. But their arms, their arms are exposed, their upper body is exposed, and then they lay down on the beach. And I've got two brothers that are surfers, and they've got very low vitamin D levels. And so in the literature, it's talking about possibility that we're losing the ability to convert the sunlight, ultraviolet radiation, to induce cholecalciferol, which is the base product, or cholesterol, if you want to go even further, into the D grouping of vitamins in the kidneys and then the liver. So, why are we losing it? Have to understand that vitamin D appears to have been a survival mechanism. The survival mechanism is vitamin D stimulates hair growth. So
really,
in the millions of years ago, when we were just starting out, if we didn't have hair, the ionizing radiation from the sun would cause cancer and we die. So we developed hair to protect us from the sun. Now we're living in caves and huts and homes and whatever, and we're blocking the sun. So the body says, oh, you don't need it anymore. It might take another million years for us to totally eliminate vitamin D from our system.
I can go back to eating wallboard. So,
you look at things like sickle cell disease, that it was, the body created it so that it would protect people living in Africa from malaria, is what they believe. So our body mutates and develops protective systems. So, the vitamin D was a protective system. Now we don't need it because we wear clothes and we're in, huts, caves called homes.
But the impact is still phenomenal. If you take, you might not need it for hair loss, but internally vitamin D can,
You look at the benefits of cardiovascular. There's almost 3 million articles on vitamin D protecting the heart. And over the last 4 years, because of COVID, people started taking vitamin D because it blocks the virus from getting into the cell, or diminishes the inflammation created by it. So cardiologists in my group, cardiologists, recognizing improvement in people with cardiovascular disease prior to, having COVID, and start taking zinc, quercetin, and vitamin D.
Dang.
So
solid COVID right there, man. But, it's, the one of the things that I wanted to ask you about is that, we talked about a lot about, traumatic brain impacts or repeated head impacts at the conference.
Right.
And now, based on the New York Times article, we're starting to finally get a lot of attention to repeated blast exposure. Now, repeated head impacts and blast exposure cause two different forms of damage to the brain. I mean, one, and eventually lead to CTE but they both create behavioral dysfunctions and psychological dysfunctions. Are you seeing any difference in how you apply your protocol to, say, a veteran or a soldier, or is the damage different that you have to repair, or not at all?
This is where we've had differences in purview and how we look at things. I don't fully. I believe that it's the same pathway of damage. What starts it can be different. You have pure emotional. You can have blast wave. You can have football. You can have concussive sports. You can have MMA. You can have jiu-jitsu. You can have rugby. You can have hockey checking against the sideboard, which is worse than the game itself. All these things create that thing we talked about called mechanical transduction that causes the cells to start dumping inflammation into the brain. So whatever the causation is, the pathway is the same. So if we would not intervene, I mean, Dr. Daniel Pearl out of health science in the military, has done over 20,000 brain segments or brain histopathology, and he found everybody had CTE. CTE is a end stage condition from prolonged inflammation that you've done nothing to do to diminish it. No, let me be very careful on this one. SSRIs, antidepressant medication, a few of them have some benefit at reducing inflammation. The majority don't. Okay, there are a couple of pathways that some of the SSRIs can drop the white blood cells of the brain called microglia that dump the inflammation. It can modify them. Then another pathway that helps with calcium going into a cell, which destroys a cell, excitotoxicity. But, you know, there's really no difference in the process. They'd like to say there is so that they can have multiple tiers of investigation. Yes, CTE is an end stage of it. CTE.
Yeah,
Daniel Pearl found CTE, found the protein in there. If you look at Alzheimer's disease has accumulation of these proteins, tau proteins, beta amyloid. What causes the tau protein to occur? Trauma causes a process that they call phosphorylation, which causes the tau protein to be disrupted from its function. What is its function? It holds the tube in our neuron together, called the microtubule. A and B is held together with tau protein. If you get too much phosphate on it, it separates it, and you start getting this accumulation of tau protein. And then you have beta amyloid, which is from disruption of an enzyme system, secretases system, and that causes a lot of beta amyloid to be produced, which creates more inflammation. So it's a catch-22. So it's understanding this molecular cellular levels of how these things occur gives us an opportunity to jump in and to alter the pathway, alter the course. So, you know, I respect those brilliant researchers who talk about CTA, but it's the end. Why don't you talk about how to stop it?
Right.
At the beginning.
So from a neuroinflammation perspective, you treat both the same way, you know, even
Absolutely.
though we have, I mean, we still have physiological damage that needs to be addressed, especially in terms of severe synaptic death, which is associated with schizophrenia, and a lot of demyelination, which, you know, these take time. And I think there are, you know, ways we're looking at it. So yeah, here's a good question. So with your protocols, how do new things, you know, so supplementation and diet are two ways that, I mean, these aren't even covered by, you know, insurance, right? And everything that you are proposing, you can buy in a GNC for the most part, right? So we can't get insurance coverage for that. And then we look at psychedelics. So how would psychedelics overlap with your therapies, or do you recommend them, or and with the promise that maybe there could be some, you know, neuroplasticity that's regained, or neuropathway rewiring in the brain? What's your position on, you know, while dealing with the neuroinflammation that's causing all the damage from the kinetic stuff? You know, how does psychedelics, what's your perspective on that?
I think psychedelics are one of the tools in our medical bag. Okay. It isn't the only tool in the bag. It is a tool in the bag. MDMA, ibogaine, ayahuasca, psilocybin, LSD, they're all tools in the bag. Now, the question is, who needs them? Well, if you give it to people as the first treatment, that might help them, because there are certain of these psychedelic and psychedelic-assisted therapies, psychedelics, which have major anti-inflammatory benefits, okay? Major anti-inflammatory. So you get some benefit from that, as well as resetting the serotonin A1 and A2 receptors, some of the DMT receptors. We're still finding out what the pathways are that are being influenced by each one of these psychedelics. So I think they have, you know, a role to play. I mean, 1952 or 53, when they were originally brought back from Mexico, psilocybin, that it was helpful in depression and addiction to alcohol and to cigarette smoking at the time. Now it's being applied for specific depression, schizophrenia, and all these other psychedelic labeled conditions. So I think they have use. We're still developing how much and what. I wrote an article that got published last year, September, which dealt with how neuroinflammation will possibly reduce the beneficial effects of psychedelic assisted therapy. Because think of it this way, everything is really straightforward. If a psychedelic needs a specific site on a cell to turn on its magic, if there's inflammation, it destroys those receptors. And if this hormone, this psychedelic, needs an enzyme to help it to work, like monoamino oxidase, MOA, and so forth, or MAO, in alpha and MAO beta, what happens is you can't make it. So you can't regulate the synapses. And that's the key that you said, is the synapses are damaged by inflammation. And if you damage the synapses, which is the communication junction between one nerve and another, which helps with the transmission of the impulse that tells our brain what to do or directs chemistry to occur. If you have loss of that synaptic junction in the chemistry because of damage by inflammation to the receptors and the production of neurotransmitters, then you lose the benefit. So my recommendation relative to psychedelics, if you're going to use them, to do something to drop the inflammation in the brain so you get the maximal benefit. And in fact, we've got a project in the British Virgin Islands with an organization called Wake with a Dr. Nick Murray. He's a Canadian doc who opened up a center in Jamaica originally, and Richard Branson contacted him and moved him over July 1st, I believe today, moved him over to British Virgin Island to reset up his psychedelic assisted therapy, which is for military and NFL right now. And so what Dr. Murray has learned, because he got trained and his head doc got trained by us, is that you need to address the inflammation prior to starting a psychedelic therapy so that you can get the maximum benefit with a lower dose. There's microdosing, then full levels of dosing of psychedelics. And I think that there was a case, I think it was Colorado, a girl with paranoid schizophrenia or schizophrenia overdosed on a psychedelic, was hospitalized. When she cleared the psychedelic and woke up, her schizophrenia was gone.
Really?
Yeah.
I've been on a little research project right now where I've done ayahuasca. I'm getting ready to try some psilocybin. I've been using ketamine for about a year now due to my, just a lot. I was having some issues a couple of years ago. And I am absolutely, amazed at, what it's done for me, from Part's perspective is, and getting back on healthy diets. And that's, and leveraging, a lot of the knowledge that's out there. It's just something that I think is important. We are working on some legislation right now where we're going to propose that programs like yours, not in psychedelics, as well as all these other technical modalities from photobiomodulation, hot tub therapy, HBOT, vagus nerve stimulation, all these other things that have had treatment. You've got hundreds, if not thousands, of veterans going, this helps me. Well, I don't think there's a need to wait on more studies or more trials when we have veterans killing themselves every day and hundreds of thousands more suffering, when they should, their only crime is, I joined the military and I wanted to fight for my country. They did not do anything wrong. And they're suffering. I went at this ayahuasca treatment. We can talk about this on another show, but I watched 12 kids that have gone multiple suicide attempts, snorting heroin, or absolutely in the deepest holes a human being could be. And they did nothing but go to war. That was their job. And they did it well. And they're suffering. These are special operations guys. We had two women in there, and they were looking at ayahuasca. And I'll tell you, 12 of them left better people. They left with purpose. Even myself, I was changed at a very deep level, profound level by that experience. But, again, all these awesome, programs, and capabilities like what you bring to the fight. These kids are out there paying $100. You want to go if you want to go take ibogaine in Mexico, it's $7,000-8,000, right? I'm paying $5,000 to take a mushroom trip here in a couple of weeks because I want to see what it does for me. So if I can talk, I talk from the core. But we've got to get these things covered by insurance. Have you had any success with the TRICARE or the VA or just Blue Cross Blue Shield?
No.
And if you haven't, what's the obstacles? How do we? Because the support that we're getting from the politicians right now is like, this needs to change, and we're convincing them that it has to change, and this is gonna change. But at the same time, we've got everything. We got thousands of veterans going, hey, this stuff helped me. And I want to give them a Chinese food menu. Go, you try whatever you want until you find the right combination. But it all starts with neuroinflammation. It all starts with what you're talking about, if you ask me.
Well, the biomarker panel that we have, the 28-point biomarker panel, in the beginning, which is back in 2004, we would attempt to send it into the different insurance companies, and a lot of times they were rejected. And the reason why they were rejected is because within our 28-point biomarker panel are some of the hormones that they believe are female important only, not male, like the pregnenolone, progesterone, allopregnanolone, which is not true. But that's what they use as a means to negate the reimbursement for these tests. The other issue is, I sat on the Medical Board of California as a consultant, as an expert for them for a while, and then as a consultant for many years. And I learned that if an insurance company doesn't like you ordering labs, they'll put a complaint in with the Medical Board of California, and the obligation of the Medical Board of whatever state is to go and investigate the complaint. So, yeah. So,
dude, no fun.
So what we decided to do was to not send anything, after that date that we decided, not send anything into insurance, and we became cash only. And what we did was started, supporting our veterans. We've got over 2,000 that we help into our program, trying to get more funding so we can get it to zero. So it's no out of pocket for them to come into the program. They'll have to pay for their treatment, which, our treatment is not lifelong. That's the beauty of it. Our treatment is until you get better. And that might take 3 months, 6 months, 9 months, or a year. We have a 56-year-old Army major from Fort Hood who's on 8 medications, came into the program. 6 months later, he's off all medication, and he's off of our treatment protocol. And in the course of that first 6 months, he's retired from the Army and gets a job working for the Department of Health and Human Services for the state of Texas, where he drags me in to give presentation and for the Office of Acquired Brain Injury. He has me go and give a presentation. That presentation was on the difference between TBI and PTSD, and the treatment outcomes were identical, whether or not they were given a PTSD or a TBI diagnosis. Their outcomes were the same. Okay. Crazy. So it taught me that it doesn't matter what label, it depends upon what you find. And what we found was the neuroinflammation associated hormone deficiencies. And when you corrected that, their symptomatology disappeared. And I posted that article on my website on the tbihelpnow.org under the science, and you can go read it. It's PTSD TBI article. And, it shows you the end results, how much improvement they had over a 12-month period of time. And that's what I presented to them. And then last Thursday, I was invited by the major, his last name is Schaefer, to present to an organization called Samaritan Organization, which are psychologists, psychiatrists that nationally go to help the different branches with TBI, PTSD, and all that. So I educated them on your subconcussive presentation that I did for you, so they understood that they don't have to have loss of consciousness. They don't have to be knocked down. They don't have to have anything. but they can progress over time to have everything.
It's nuts. I spoke to 150 lawyers, nonprofits, and judges, all dealing with the criminal system here in Tampa. And I said, all right, how many of you heard of repeated head impacts? 4 people raised their hand. And I said, do you know that not only do we have 1 million incarcerated veterans who have never been assessed, Dr. Gordon, never been assessed for any, overexposure to repeated blast injuries, RHI, so where they might not be completely at fault for their actions, we'll just say.
Right.
But, we have enormous amounts of incarcerated. I've heard of studies, haven't found them yet, where 80 to 90% of the inmates have had experience with TBI or MTBI in their life.
To you.
Really? I mean, just think of the cultural change that could be happening if we were more aware of what we're doing with brains. We're aware of the fragility of them and stuff like that. And I know, it's amazing. But look, I know we're taking up a lot of your time here, but this is you're definitely coming back on. Not like this ain't Joe Rogan yet, but you're definitely coming back on.
Well, the article came out and stated over 1 million veterans incarcerated, 235,000 are females, and that in greater than 90% of them had at least one hit, one concussive trauma, one TBI. Okay. And if you look at the causations, sports related. Okay. Majority of them were sports related. And then they go into the military. You see, even Andrew Marr, you met Sergeant First Class Andrew Marr, Green Beret, EOD. He was a football player from childhood, Pop Warner, all the way up to college. And then he goes into the military, and he has, in his 4th tour of duty, he has this blast that knocks him unconscious for 5 seconds. And 6 months later, he's on 13 medications, full-blown alcoholic and suicidal. And they're calling him PTSD.
No, it's got nothing to do with it.
They didn't look at his history. They didn't see. No. And what we did in all these, on the study that I told you about from last March, was we looked at the guys who gave PTSD or were given a PTSD diagnosis. 100% had prior traumas.
Just think of the change. The change, we can't even calculate the loss of human capital that's taken place from the lack of awareness of this issue. But just think of what could happen if every doctor, nurse, athletic trainer, psychologist was aware of the impact of these various professions and occupations on the brain and just started assessing these kids. I mean, look at my coroner. If it wasn't for the coroner that asked me that one question on CT about my son, I wouldn't probably be here. Right. Yeah. But he at least attended the seminar. He represents less than 1% of the coroners in this country. How many suicides take place that are labeled suicide? Sorry, kid's gone, or your husband's gone. And nobody's saying, did your husband play contact sports? Because we're not aware of as a society. And I think it's appalling. I mean,
and it could be a car accident. We have a 29-year-old female who was in a car accident 3 years ago, subsequently developed paranoid schizophrenia. And
years later.
3 years later, she's in Florida.
Plug my computer in. Keep talking.
This is in Florida, in fact, with Dr. DeMaio, who shared this case with me, and that this gal was going to be incarcerated into the State Psychiatric Institute, and her doctor, a naturopathic doctor, referred her over to Dr. DeMaio, who ran our 28-point biomarker panel and found these deficiencies, corrected the deficiencies along with anti-inflammatory nutraceutical products. And what happened within 6 months, she's back normal. No longer paranoid schizophrenic. Right. That's why you need to get Dr. DeMaio on this program to talk about the pure psych.
If you could, I mean, we can't get the American Association, we can't get any psychiatric folks to talk to us about this because we're not, look, man, we want to work with you to get this knowledge into your base so we can start working on saving lives, and
that's too practical, Bruce. That's too pragmatic. That's too practical.
I'm a stubborn guy.
They want to show that it's psychiatric, little blue pill, little green pill, as opposed to causation. They're looking at the end stage, and this is what my battle is. We have to look at the beginning, middle, and obviously the end stages. Well, if we can jump on board early enough, we can stop that suffering leading up to the psychiatric emotional changes. That is my goal. That has been my goal for the past 30 years, since I've been in this venue since 1995 to now. It's 30 years. My true transformation came about in 2004, and then 2009 with the military, and learned a lot. I read a lot, I learn a lot from experience, and there's a lot more that we can do in terms of getting the information out there. How to get it out there so that people will take you seriously is my battle. Yeah, I was called by NATO for Ukraine. I'm going to Australia with Paul.
Yeah,
to start the
Buckland,
process
man.
there.
Yeah, Paul. Yeah.
Paul.
No, I'd love to help you. I love Australia, man. I'm working with Paul on a lot of initiatives right now because he's aware of it, and Australia's there's another huge all the lawsuits in Europe right now that are coming down. So good for you for helping him out, man. That's amazing. And
I'm frustrated. I'm frustrated, Bruce, because I think my efforts and the efforts of the group of docs that we've trained should be here in the United States, not going off to Ukraine or to Australia. Or, I was in the UK at the invitation of the Ministry of Defense and the Military Surgeon General at at Imperial College to explain why their top SAS guys were flying into Los Angeles for assessment and treatment. My simple answer was maybe they want to get better.
Yeah.
How many people don't want to get better? Well, don't you think, not you, but don't they think that we need to find what works? And we have, as of this morning, 9,382 people in our program. 2,000 are military.
Paying out of pocket.
And
trying to get better.
Well, I'm self-funded. I generate funds from everything I do, and I help to bring them in.
No, it wasn't that. My point was, Doc, is that you should be getting paid from insurance costs.
Yes.
They're whether it's you or anything else, it's a big problem. And we caused this. Society is what, we sent these men and women to war, okay? They came back, and I've been there 4 different times, right? They come back, and then they want you to be some kind of choir boy, and if you act out, it's your fault. And you got to pay the price. And it's just a wrong way to address, the sacrifices that have been made. And I'm like you, I'm frustrated. I have been fighting as long as you have, but in 3 years, I've created a lot of ways.
Accelerated course.
We are we're pushing, and I just think that you've got an important ingredient to the solution of this problem. And I looked on your website today. How many, like you talk about your cadre, you got like districts that are you got like quite a list of, a channel of providers that you've trained up for your protocols.
We have about 117 facilities in 12 countries. I own none of them. They don't pay me anything. What they do is they took my class, they took a live class or online. They learned about, the software that helps them to accelerate the ability to perform at the same level as we do. And I encourage them. I check in on them periodically. They don't pay me for checking in on them because it's the greater good that I'm looking to have as the outcome. Yes, the Millennium needs funding so that we can continue paying more for our veterans. It was originally $2,500. Now they're paying $1,000. Even though the laboratory costs are $3,000, they're only paying $1,000 for the program. And I'm trying to get it so that
buy
it's
a laboratory. How about we just buy a laboratory and put some people in it to do the panels for like nothing? How's that?
I'm close enough to the one in Florida in Jupiter, Access Medical Laboratories, who have just given me funding for a new project for our veterans to test out one of our new mushroom products. It's medicinal mushrooms that are all for dropping inflammation. I'll send you the paper I wrote. I haven't disseminated it, but we're going to do the study. Access Medical Lab, very, very kind to have funded us for 30 guys to go through some really high-end specialty testing for inflammation, neuroinflammation, using cytokine markers, and to test this product. If the product drops the cytokine, we've got a good product. If the product doesn't drop the cytokines, the inflammatory chemistry of the brain, then we don't have a good product. And that means that the product we've been using right now that does a very good job is the stuff you already tried, the Brain Rescue 3. Cool. Which is our #1 product at improving cognitive function, emotional stability, because it helps to drop inflammation in the brain. So,
you know what I like, Doc, is you. No, I mean, amazing. And what I thought, what you just said really impacts me, because this is the gap. This is what I don't see out there, is the greater good. Okay, whether it's politics, it comes to soldiers, it comes to our kids. Everybody's got an angle, right? I got to, I got to do this, I got to sell that, I got, or it's got my ego. The ego in this medical world blows me away with the people that will not work together for the common good. Well, we here at the Mac Parkman Foundation, that's all we care about. We've got children dying. All my NFL friends are a mess. And I don't have a lot of them, but the guys I've met that, I'm pretty close to, because NFL knows one thing. NFL veterans and soldiers get along really well, dude. I don't know why. We get the same mentality.
You're both fighters. Yeah. You're both
I was like, man, you could have been in the Army for years, man, But, we just got all this carnage that I just refuse to not see. And I think, folks like you, are just out there in front of this. And I want people to know, if you need any volunteers for that project, you let me know. We'll get the word out. I'll get you folks. There's no doubt that.
Well, and if you've got some veterans, I'm just filling out the paper, the screening paper. I'll send you a copy of it. Let me just put a note down. I'll send you a copy of it, and you can disseminate it to any branch, any individual, male, female, doesn't matter. But they have to have the criteria, exclusionary criteria, because there's certain things they can't be taking, because that will impede the results that we're looking for if they happen.
Absolutely. Okay. No, we'll help you get that out. And then, let's keep the conversation going, sir. I mean, It's been an amazing podcast and a great journey, and I can't thank you enough for the time, the opportunity to help.
Thank you, Bruce.
Spread the word on what you're doing, and we will push it out there. Every time you got something new, send it out to me. We'll get it out there. Get it out there for you.
Okay. Appreciate it.
Well, Dr. Gordon, cannot thank you enough for coming on the show. It's been an amazing talk. Thank you for all you're doing for our veterans, our kids, our parents that love to have their kids back. I mean, of course, I wish I had my son back every day, but this is the way I've got to make him proud. So your pivot to subconcussive trauma has just made me joyful as all get out. And let's go take on the establishment.
Thanks for the redirection that you gave me through your subconcussive trauma.
No, that conference in D.C. is coming up next year. It's going to be big, and you're going to be a part of it. Who, sir? All right. Well, thank you so much for your time. Next on, we'll have you back again. Folks, Dr. Gordon, amazing man, amazing products. Please take a look at what he's doing for the people that we love. And thanks a lot for your time, Mark.
Thank you, sir.